Welcome to the Vector National Thrombosis Seminar, where this is a monthly seminar hosted online throughout the academic year, featuring state-of-art thrombosis and VT lectures presented by both Canadian and international experts. I will remind you that the video recording also will be available in case if you want to refer to it later on the Vector website. And the Vector National Thrombosis Seminar is a self-approved group learning activity qualified under Section 1, defined by the maintenance of certification program of the Royal College of Physicians and Surgeons of Canada. So these are the planning committee. I think you have seen it before, chaired by me, but we also joined by really excellent planning committee members, which I really appreciate to work with us to put up a good seminar for you throughout the year. So today, I'm very, very excited to have this topic, antiphospholipid syndrome with the new criteria and hopefully new era, by two distinct and very excellent speakers, Dr. Mark Crowther and Dr. Antonio Capro, who will give us perspective from different perspectives from both thrombosis and rheumatology. I think I was told that it is actually surpassed our biggest registration so far. We have more than 150 attendees or registration, which just, indicate that there's a lot of interest. So Dr. Mark Crowther, I probably don't have to introduce too much, but Dr. Mark Crowther trained in hematology and thromboembolism at McMaster University. He's the chair and professor in the Department of Medicine and the Leo Pharma chair in thromboembolism research at McMaster University. He's also chair of the senior Research Committee for the Heart and Stroke Foundation of Canada, past treasurer of the American Society of Hematology, and past president of the Anticoagulation Forum. Dr. Crowther's clinical activities focus on patients with thromboembolic disease. His research examines methods to prevent and treat thrombosis. Dr. Crowther has more than 580 peer-reviewed publications with an H factor of more than 130, and has presented at more than 550 meetings worldwide. He has been inducted into the Royal Society of Canada, the Canadian Academy of Health Sciences, and has been awarded the title of Distinguished University Professor at McMaster, and has recently completed his LLM at Ascot Law School. Dr. Antonio Capro is a rheumatologist and the head of rheumatology division at the Ottawa Hospital, University of Ottawa Department of Medicine since 2015. He received his medicine and internal medicine degrees from the University of Mexico in 1976 and 1981. He then spent 5 years at the Division of Hematology at University of Michigan Medical School in Ann Arbor as a research postdoc fellow under Dr. William Castor's mentorship. He went back to Mexico to work as a research scientist at the Department of Immunology and Rheumatology in the National Institute of Nutrition and Medical Sciences in Mexico City, where he had a productive research career for 30 years, passionately studying the serological and clinical characterization of the antiphospholipid syndrome. He has trained more than 47 rheumatology residents from 9 different countries. So the learning objective for both talks is listed here. I won't read them out. They are, these will be available for you as well. Please just a reminder that we will have a 15 minutes Q&A at the end, but please feel free to, submit your questions throughout the seminar using the Q&A and chat function, and we'll address all of them at the end. Now I'll give the floor to Dr. Crowther.
Excellent. Thank you, Suve, and thanks to everyone who's attended. And I'm just looking at the participants list, and hi to everybody out there who I know. Hi, Ed in British Columbia, and Andrea and Windsor, and all the rest of you. Pleasure to be here today. And I'm happy to talk about this, which has been near and dear to me, as many of you know, for close to 30 years. So I have control of the slides, so I will click. So my first slide is just the intro slide, and my conflict of interest disclosures are here. None of them are relevant to APS. Nobody's really interested in APS from a pharmaceutical standpoint, but as many of you know, I have worked for pharmaceutical companies and reversal agents over the decades. The objectives for today are to just understand some of the key changes in the guideline, in the documents that outline the diagnosis for clinical research purposes of APS, analyze some of the rationale, and then talk a little bit more about some of the case-based stuff. And then Dr. Cabral will do a much more deep dive into some of the specific characteristics. So the first introduction is just a quick overview of APS. I think we all know APS is a systemic autoimmune disorder characterized by thrombosis and or pregnancy morbidity in the presence of this set of lab tests, which we refer to as antiphospholipid antibodies. It's got some unique characteristics in that it's associated with both arterial and venous thrombosis, which relatively few thrombophilias are, and it can affect both large and small vessels either independently or at the same time. Classification criteria we're going to talk about today are for research purposes. They aren't meant for clinical purposes, but in reality, everybody's going to apply them instantaneously to clinical cases. And so although what I'm talking about is for the research use, in reality, these are going to affect the way we make the diagnosis of the disease. And the underlying question I get asked a lot when I do this talk is, why did we change these things? And I was just saying to Dr. Cabral that Doruk Erkan and I decided we should try to get these criteria changed more than a decade ago, and Doruk put an enormous amount of work into this. So this project is entirely thanks to Doruk Erkan, who works in New York. He's a great guy, very interested in improving the science of antiphospholipid antibodies. And our goal was to refine APS criteria to produce higher specificity, that is to remove some of the iffy cases so we had a better understanding of the disease. And as a result of that, strengthen the foundation of APS research by making sure that the people who we thought had the disease actually had the disease. So if we move on to how these scoring system, or the scoring system was designed, it was different than the first two, the very famous Sapporo criteria and then the Sydney modification of the Sapporo criteria, in that this involved a very large group of people, actually many hundreds of people scattered over the world over a period of more than 5 years. It was a true multidisciplinary approach, and it had multiple phases of development. So we had a large collaboration, which involved some face-to-face meetings before COVID-19 and then electronic meetings during COVID-19. There were rheumatologists, hematologists, obstetricians, and lots of other APS experts from around the world. It truly was multinational. There were 4 phases, which involved a great deal of work from many people: criteria generation, reducing the number of criteria, defining and weighting, meaning how are we going to score things, and then a validation set. And it used literally hundreds and hundreds of cases of patients who we thought didn't have APS, might have had APS, and did have APS, gathered from clinics around the world. So thank you to very many people who did this project. It involved a technology called Delphi surveys, which is a well-established way of defining best practices in the absence of good quality evidence. There was extensive literature reviews, several expert consensus meetings, and then, as I said earlier, many, many real-world patient scenario analyses from cases that were provided by a large number of people. In phase 1 and 2, we decided what we were going to talk about, and we initially had an enormous number of potential criteria, which spanned everything you can possibly think might be associated with lupus or with antiphospholipid antibodies. So we had to reduce that down to a manageable number. And even with the reduction, as you'll see in a second, it's still super complicated. We then had to define criteria and weight things. So we got a scoring system. And in the end, we had to then do a validation. And when we look at the sort of 150,000 foot level, what are the differences? So the first thing is that the criteria maintain the same basic concept. You have to have a clinical presentation and a laboratory presentation. But the advantages or the advances are, first of all, there's a weighted additive system, which gives you a lot more flexibility and allows us to rule out or rule in cases based on their clinical characteristics or their laboratory testing. Secondarily, there's now still 2 laboratory domains, that is the traditional lupus anticoagulant and anti-cardiolipin antibody, or beta-2-GP1, but there's now 6 clinical domains instead of just 2. In order to exceed the definition of having the disease, you have to accumulate a certain minimum score in the clinical and the laboratory categories. And I'll show you a couple of cases where I think this becomes extremely useful. So what's changed? The 6 clinical domains have changed. So thrombosis, both arterial and venous, pregnancy morbidity, cardiac valve, hematologic manifestations, neurologic manifestations, and then kind of a group of different manifestations that don't fit into any one particular area. And I'll tell you about these when I show you the graph in a second. And then the laboratory domains, and really they stay the same: lupus anticoagulant, anti-cardiolipin, anti-beta-2-GP1, but it does actually provide us with a lot more refinement of the importance or lack thereof of IgA determinations and of IgM determinations, which are a bit of a bugbear for those of us who work in the field. So when we compare the results of using the new criteria with the 2006 revised Sapporo criteria, we have increased specificity, Specifically, we did this to reduce false positives. Secondarily, as a result of having increased specificity, there's slightly reduced sensitivity. And so the reason we thought this was important is that the second small bullet here, you can't prove a therapy works if the patient you're treating does not have the disease you are treating. And so we wanted to eliminate as much as possible false negatives, false positives when we were saying, does this patient meet definition and should they be included in a study? The results of these changes are more accurate APS diagnosis and ultimately, presumably, personalized treatment plans and improved patient outcomes. And more importantly, standardized APS research methodologies, allowing us to compare results between studies. Anybody who's tried to do systematic reviews in the world of APS will realize there's many different definitions. And as a result of that, it's really difficult to do systematic reviews. The other thing about these guidelines is they're meant to be evolving or living. So there's a plan for ongoing validation and refinement. And we hope to be able to refine these future, not only based on clinical criteria, but more importantly, as we discover and validate new biomarkers, they'll be incorporated. It's really important to realize that clinical judgment remains important because APS is ultimately a clinical, not a laboratory disease. And these criteria, as I mentioned, are to be used in research settings, but in reality, we know they're going to be used in the real world. So this is, and I made this intentionally hard to read. This is actually taken from the paper that was published simultaneously in North America and Europe. But you can see it's really very complicated compared to the old one. The summary is, while that's complex, it involves a much more granular and inclusive classification criteria. It's informed by 20 additional years of observation and thought since the last time these were revised, and it employed a much more rigorous development process. So what are the 6 clinical fields? So macrovascular disease, venous and arterial, that's 1 and 2. Microvascular disease, a wide range of conditions, including things like pulmonary hemorrhage. Cardiac valve disease, which is new. Thrombocytopenia, which is new, and the obstetrics complications, which have been refined significantly. And then we have the laboratory criteria, and I won't go through those in depth other than to say that they're basically the same. However, we've completely eliminated IgA testing. There's no value in that. And we've refined greatly the value of IgM testing. Some of you will know that I'm not a big believer in beta-2 glycoprotein 1s for a reason we won't talk about today. However, I wasn't able to completely eliminate it from here, but we've certainly downgraded its responsibility or its contribution as well. So the best way to use this criteria, because it's so complicated, is a calculator. There's a whole bunch of calculators out here. I cherry-picked this one, and when I made the slides, I said, you should use this calculator. It's from something called RoomCalc. It actually has some errors in it. So in retrospect, you shouldn't use it, but there are other calculators out there that have been put together that are highly, very useful way and much simpler way of determining the score than trying to remember the classification criteria yourself. So I've got 3 or 4 cases, and then I'll turn over to Dr. Cabral. So the first is a 72-year-old male with a history of recurrent pulmonary hemorrhage, adrenal insufficiency because of prior retroperitoneal hemorrhage, and chronic moderate thrombocytopenia. He has a high titer persistently positive IgG anti-cardiolipin antibody, and he had a lupus anticoagulant that was positive once, but it's now negative. In the old classification criteria, this person probably wouldn't have APS because it was a little bit controversial about whether the pulmonary hemorrhage or the retroperitoneal hemorrhage, which is due to adrenal thrombosis, would meet criteria. But I think most of us would feel this gentleman would not meet the prior criteria, partly because he doesn't really have a macrovascular complication that we would understand. The thrombocytopenia didn't count. And his APS serology, strongly and persistently positive anti-cardiolipin antibody, but transient lupus anticoagulant, also may or may not have met the criteria. Most of us probably would have said this guy doesn't have it. But if we look at the new scoring system, he gets 2 points for the pulmonary hemorrhage, 5 points for the adrenal insufficiency secondary retroperitoneal hemorrhage, which is due to adrenal vein thrombosis, 2 points for the thrombocytopenia. In order to have the disease, you have to have more than 3. So he's got 9, which easily exceeds 3. And the persistently positive high titer IgA anti-cardiolipin antibody gives him a score of 5 and 1 for the lupus anticoagulant. So even the transiently positive lupus anticoagulant moves towards a diagnosis. This exceeds 3. So this gentleman has APS. And so in the new criteria, this is a solid case of APS, whereas in the past one, he would have been at best iffy. Second case is a 42-year-old woman who has a strong history of vascular disease and who unfortunately has smoked for decades. She presents to the hospital with a stroke. Laboratory testing shows a persistently positive high titer IgM anti-cardiolipin antibody and IgM anti-beta-2 GP1 antibody. At the time of the stroke, she had a positive lupus anticoagulant, which is now negative. And again, most of us would probably have said under the old criteria, this is a 42-year-old with a stroke, and who has persistently positive serology, she probably has lupus anticoagulant. She gets 2 points for the stroke because it's a stroke which occurred in the setting of risk factors. That is, she smokes, family history. She gets 1 point for her IgM ACA, even though it's high titer, and 1 point for her lupus anticoagulant because it's transiently positive. So she does not meet the criteria. So this woman would probably have before been classified as having APS and is now classified as not having APS. Just modify that a little bit. So if you remember the previous case, this is the same woman who has a strong family history of vascular disease, has smoked for decades and has a stroke. Her laboratory testing is exactly the same, but she now has a history of ITP. So now you're thinking, wow, this lady's definitely got APS because she has thrombocytopenia plus a stroke, although that didn't count before the thrombocytopenia. She now gets 4 points on the clinical side, but her lab testing hasn't changed. She gets 2 points, so she doesn't meet consensus criteria. So despite the fact she has ITP, this woman still does not have, doesn't meet the criteria for APS. And then let's just change the case a little bit more again. Now we're going to say a 42-year-old woman, strong family history, has a stroke, has a long history of ITP. She has a persistently positive moderate titer IgG anti-cardiolipin antibody and moderate titer IgM anti-beta-2 GP1. At the time of stroke, she had a positive anticoagulant, which is now negative. Now, because she's got a persistently positive moderate IgG anti-cardiolipin antibody, she gets 4 points for the anti-cardiolipin antibody, 1 point for the lupus anticoagulant. So now she has 3 points in more than 3 points on both scales. So she meets the consensus diagnostic criteria for having antiphospholipid antibody syndrome. So in terms of the thrombosis part of the guidelines, this is the CAN vector after all. It includes a much wider range of microvascular thrombotic diseases that were possibly inclusion criteria under the previous recommendations, like pulmonary hemorrhage and adrenal hemorrhage, which are presumably due to thrombosis and back pressure. It allows for a longer period of laboratory testing to make it easier to screen patients quickly. If the patient had testing done 2 years ago, it was positive. It's positive now. That is enough for the diagnosis. This allows some refinement around large vessel thrombosis about whether it occurred in the setting of risk factors or not. It allows stacking of risk factors in a way that the old criteria did not. The disadvantages are it's far more complicated. It's going to take a scoring system to use it. It leads to more difficult discussions with patients because you have to explain things like cardiac valvular disease, and it requires a more careful review of prior lab testing because you need to know whether it was IgM or IgG and whether it was moderate or high titer. I think this is my last slide. So case 3 is, I think, a really good case, one of the cases where this is going to be very helpful for clinicians. 24-year-old woman with lupus, so she's got a high risk of having APS, goes skiing, fractures her leg, is placed in the cast, and is then emerged 3 weeks later with an extensive left leg DVT. So there you go. Lupus, fracture, DVT, 4 prior pregnancy losses before 10 weeks gestation. This is kind of screaming APS. Laboratory testing shows a persistently positive high titer IgM anti-cardiolipin, IgM anti-beta-2. At the time of the stroke, the DVT, she had a positive lupus anticoagulant, which is now negative. She does not meet criteria. She gets 1 point for her DVT because it occurred in the setting of a risk factor. That is that she had a cast on, she'd had surgery. She gets 1 point for the recurrent pregnancy loss. We've downgraded the importance of losses before 10 weeks. She gets 1 point for her IgM anti-cardiolipin antibody, 1 point for her lupus anticoagulant. She gets 2 points in each scoring system. She does not meet criteria. And this is going to be really useful, again, when clinicians use this for clinical diagnosis, because in this woman, if you say she has APS and she's had an extensive DVT, she's probably looking at lifelong anticoagulation, perhaps with warfarin. And if you say she doesn't have APS and she's got a clear secondary DVT, she would be treated with direct oral anticoagulants for 3 weeks and then stopped. So this is a patient in whom it would be superb for us to have these criteria and be able to use them clinically, because it would allow us to stop our anticoagulants at 3 months, which I think is probably what most of us would do with just a little bit of additional attention for her additional risk factors for recurrence. So with that, I will end there and I will turn it over to Dr. Cabral.
Thank you, Dr. Carter, for your excellent presentation. And indeed, it was a good setup for mine. I'm not advancing. I'm not, okay. My objective is to highlight a little of the novel aspects of 2023 ACR and Euler APS classification criteria, different from what Dr. Crowder did. Discuss this classification finally acknowledges that APS may have multiple clinical phenotypes. I will use the case of thrombocytopenia to convince you that how the new set of criteria still uses self-evident biased expert diagnosis to classify what APS and what is not APS. As you know, there are currently, the current criteria were referenced from the what we knew about this the name by the name of Sydney criteria, but there was a preliminary classification criteria for the APS within SLE in 1992 by the group of Mexico. By then, I was already working in that group, but I didn't participate in the elaboration of this. So I will talk to you about this a little bit more. As you know, the international statement of the Sydney criteria, as Dr. Crowder mentioned, is the combination of thrombosis and or recurrent pregnancy losses with persistently positive tests for lupus anticoagulant and or anti-cadolipin and or anti-beta-2 GP1. So that were classified as having APS. So the other criteria were set up like labeled as second-class citizen, including thrombocytopenia. So the new criteria, as you already mentioned, heard mentioned from Dr. Crowder, is a big effort of a lot of people from around the world. And they were published in two at the same time in Europe and in North America, in the Arthritis and Rheumatology and the Annals of Rheumatic Diseases. The entry criteria, as was already mentioned, and you have to have the golden standard, which is antiphospholipid antibodies. If you don't have the antibodies as was defined, you could not have antiphospholipid syndrome. And that's very well characterized. Why? The new ones are the cardiac valve thickening and vegetation. And I was very pleased to actually see thrombocytopenia finally made it to the antiphospholipid antibody syndrome criteria. And you will see why. These are the tests that are required and the number of points. I want to spend some time looking at this validation phase. And on top, you can see that about 73%, 75% throughout both validation cohorts were female. So that's automatically 25% will not qualify as having fetal loss, of course. Someone can say that these have been not appropriate, but you have to, men cannot qualify as having fetal loss. So that's a big undertaking. And now, as you can see here, the frequency of cardiac valve thickening and vegetation is only 4% in both cohorts. Actually, but those who have APS and those who have not APS. And these numbers are pretty much what has been published in the literature for many, many, many years. And as you can see here, 25% of patients with antiphospholipid syndrome do have thrombocytopenia, which is, again, the number that you will see published in many, many, many series throughout the world. Robert Ruby from Chapel Hill, Sayus Amura, an internist from the Sorbonne in Paris, and Hannah Cohen from the University College of London were the independent adjudicators. So they used what they knew about it, about what antiphospholipid syndrome was and was not. So they have to lean very heavily on their diagnosis and what the areas of expertise have been throughout time. So that's exactly what I mean, but this is self-evident, a priori biased diagnosis that are better now than they were for the revised Sapporo criteria, at least with respect to the specificity, but they have to concede lower sensitivity. And that's probably because the increased sensitivity or specificity, is because of the inclusion of thrombocytopenia. Now, as already Dr. Crowther mentioned, these are classification criteria, but it will not be, we will see clinicians use this as a diagnostic criteria, which is or may be a mistake. And this is a disclaimer that you will find in the publication in the Arthritis and Rheumatology from the American College of Rheumatology, saying patients diagnosed with a particular disease may or may not fulfill classification criteria for that disease. Classification criteria in the hands of an experienced clinician with expertise in rheumatology may inform a diagnostic evaluation, but improperly applied classification criteria that may lead to misdiagnosis. And that's exactly what I'm going to do. The case of immune thrombocytopenia comes into my mind. As you know, thrombocytopenia is the D7 domain. And the question is, if a patient has thrombocytopenia with persistently positive tests for ACL and or lupus anticoagulant and or anti-beta 2 GP1 may not be classified as having APS, but does the patient have antiphospholipid syndrome as the diagnosis? It's been known for a long time that the antiphospholipid antibodies are very, very frequently found in patients with ITP, and it depends on the series that you can find. It can go from 25 to 73% with an average of 43%. I would say 25% of patients with immune thrombocytopenia are positive for antiphospholipid antibodies. So I had the opportunity to see which is a 51-year-old woman, in my APS clinic on April of 23, and she was referred from my colleague in hematology with positive ANA and polyarthralgias. Her personal medical history was important because she was diagnosed as having ITP, diagnosed in August of 2021, initially presented with 5,000 platelets and menorrhagia. She was known to be steroid responsive, failed to rituximab, did not tolerate Revolade, and she had 2 miscarriages, 1 at 11 weeks. Her current treatment was Nplate, which is on a taper, and I put her on hydroxychloroquine and isothioprin on August 15. On physical examination, she had normal joints. Very importantly, on MSK ultrasound of the joints, she did not have grayscale and had negative Doppler, so she did not have any evidence of synovitis. Her serology was positive, as I said, for 320 and 160/40 with a homogeneous pattern. We don't know at this point yet what the specificities of the ANA is. Her anti-double-stranded DNA were negative in 2 occasions. Her rheumatoid factor was negative, and C3, complement C3-4, were normal. This is her antiphospholipid antibody profile. In both occasions that we have tested it, not 12 weeks apart, but I don't think that's very important, were positive. Her anti-beta 2 GP1 IgG is almost 6,000, and on repeated, it was over 61,000. Her IgM 121 of anti-beta 2 and 132, so low titer. Anticardiolipin is 1,362 on the first occasion and 1,700 on the second occasion. So she is triple positive antiphospholipid antibodies. As you know, she has high risk. So if you take that into consideration for her, and you take platelets only with the triple positive, the individual is not classified as having APS, but she had a miscarriage a long time ago, but not over 3 years. But if you don't take that into consideration, or if you take that into consideration, I propose that this patient is classified as having APS, regardless of when she developed the pregnancy morbidity. Now, the question has always been, is MMM, my patient, at risk of developing thrombosis? And as you know, there are many evidence that the risk of thrombosis in patients with primary immune thrombocytopenia and APS antibodies, a systematic review in which they reviewed over 1,574 patients. The answer is yes. The risk is higher in patients who have lupus anticoagulant, and you can see the numbers here, less for anticardiolipin antibodies. So the take some messages is the presence of lupus anticoagulant in this systematic review was strongly associated with the occurrence of arterial and venous thrombosis. Now, the question is whether a patient who has thrombocytopenia and or hemolytic anemia and antiphospholipid antibodies can develop antiphospholipid syndrome. So knowing that the preliminary classification published in 1992 included thrombocytopenia as part of the definite classification for antiphospholipid syndrome, we set up a project in which we included patients from the local antiphospholipid syndrome patient registry that fulfilled the Sydney laboratory criteria. In my former job, all patients had thrombocytopenia defined as the Sapporo and APS criteria, hemolytic anemia, or both, and we excluded patients who had lupus or anti-double-stranded DNA, TTP, DIC, and heparin-induced thrombocytopenia. And these are the results. We studied 187 patients with primary antiphospholipid syndrome, 55 of which fulfilled the Sydney lab criteria. 35 of them, 63%, had thrombocytopenia. 25 developed or had autoimmune hemolytic anemia, and 6 had both. We followed them retrospectively for 5 or 6 years, and these are the results. 25% of them, at the end of the follow-up, also fulfilled one Sydney clinical criteria for definite APS. 13 developed thrombosis, and 12 developed pregnancy morbidity. And interestingly, half of them remained purely hematological. And this was a potential explanation of why when some of the group developed thrombosis and the other group did not. And it's the presence of lupus anticoagulant, as you may imagine, and has been proven over and over and over. And then we published that in 2010 with my 2 collaborators, Lucia and Gabi, respectively. So we proposed that the Sydney APS criteria should be amended and include thrombocytopenia as part of the syndrome. As I was part of this task force in 2011, and these were our proposals. We suggest that thrombocytopenia should be incorporated in the clinical criteria of APS. We thought that a multicentric international perspective long-term follow-up study of patients with ITP is needed, thrombosis being the primary outcome. We propose an international registry of APL-positive ITP, and a collaborative study with our hematology colleagues is really needed. None of these recommendations have happened. So we have the opportunity to know and learn a little bit more about this. So these are my conclusions. Yes, the new criteria, whether you patients have domains 1, 2, 3, 4, and or 5, plus persistently positive test for lupus anticoagulant, that is D7, anticardiolipin and or lupus anticoagulant, and or anti-beta 2-GP1, which is D8, can be diagnosed as having antiphospholipid syndrome. Then you can therefore go on and classify them as having different phenotypes, only with one clinical manifestation, whether it's thrombotic, obstetric, hematological, cutaneous, neurological, pulmonary, and myocardial phenotypes. This is not an original idea. We use this for lupus all the time. We have been using this for lupus for over 30, 40 years. And then you can go on develop a project, a research project, and include patients who fulfill the diagnosis of, let's say, hematological APS, thrombocytopenia with triple positive, and you put them together and follow them up, which is something that needs to be done urgently, in my opinion. So the APS elephant has always been an elephant. It depends on how you see it. If you think that the thrombocytopenia is not part of the syndrome, then you're going to miss it. If you think that recurrent fetal loss is only enough to classify or diagnose patients with antiphospholipid syndrome, then you're going to miss a whole picture. What I'm saying here is that the APS elephant we are taught to identify elephants, and once we see elephants, we say, hey, look at that. That is an elephant, but an elephant has always been an elephant. So my take-home message, although thrombosis has been the seal of APS identity, non-thrombotic manifestations are clearly part of the syndrome, whether it's primary or secondary, which was not addressed in the current APS criteria, as it shouldn't. I don't think so. So it took about 17 years to update the Sydney revised APS updated classification criteria, and more, in my opinion, than 30 years to acknowledge that thrombocytopenia is a frequent clinical non-thrombotic manifestations of human APS, and in mice APS as well, more so than pregnancy morbidity. Thrombocytopenia, which is results I didn't discuss, may antedate, follow, or appear at the same time as with thrombosis and other APS clinical manifestations or clinical criteria. As we all know, APS is an evolving entity. There is increasing evidence that the lack of lupus anticoagulant is an independent risk factor for developing thrombosis in ITP patients. And I want to ask you, do we need to wait until an ITP patient suffers non-provoked thrombosis to call it hematological APS or whatever you want to call it, in the presence, of course, of high-risk APL profile? Do we have to wait then for a woman to develop recurrent miscarriages to diagnose her as having obstetrical APS? My proposal is you need only one, because you cannot tell a woman you only have one fetal loss. If you have another two, I will see you in 5 years. What is the frequency of triple positive APL profile in immune thrombocytopenia? To anticoagulate or non-anticoagulate, that is the question of patients with APL triple positive in ITP, and the direct oral anticoagulants. It's warfarin or DOCA. Yeah, thank you very much for your attention.
Well, thank you. Thank you very much for both speakers for excellent presentations and talks. I think we have a lot of questions already coming in, so thank you. So we'll start with addressing some of the questions, and please, just a reminder for all the audience, please feel free to continue to put in the questions, and we'll try to address as many as possible. So I think Dr. Rita Selby put in two parts question. So I will read about the first one, and then we'll also go to the second one. So I think it's addressed to you, Dr. Crowther, mainly about laboratory assessment for cardiolipin beta-2. So the lab criteria for anticardiolipin and beta-2 glycoprotein 1 recommend ELISA testing only. This may make sense as research criteria for the ELISAs are validated across the APS Action Core labs. However, this has created a panic among clinical services like mine because no one uses ELISA anymore, and folks are thinking, do they have to switch back to ELISA? Can you reassure? Also highlight that the inner assay variability of ELISA are as awful as non-ELISA methods. So this is the first part.
Yeah, so thanks, and thanks, Rita, for the question. When we went into this discussion, my primary goal was to figure out how we were going to handle all the various other antibodies, because there's still people who like antiphosphatidylserine and antiphosphatidylcholine and antiphosphatidylethanolamine, and also who really like IgA antibodies. And so I must say that the energy that I invested in developing these was around trying to rationalize the high-level recommendations, not around the technology. I think everybody who's ever worked in the lab, as I have, and as Rita does, knows that anticardiolipin antibody testing is awful, as is beta-2 glycoprotein 1 testing. And it's been very hard, even with standardization efforts, to improve the inter and intra-laboratory reliability of anticardiolipin antibody testing. Rita's question is really about the specific technology for research purposes. As you mentioned, we stuck to the terminology of ELISA simply because that's where most of the data is. I would think, to answer Rita's question, should you go back to doing an ELISA? Absolutely not. I would presume that if your laboratory is using one of the couple of different technologies that are available, you've done some form of cross-validation with an ELISA standard. And if you have, I would be very comfortable with you continuing to use the test that you've used, realizing again that, you know, that the laboratory performance characteristics of anticardiolipin, to a greater extent, and anti-glycoprotein beta-2 glycoprotein 1 testing to a slightly lesser extent, is extraordinarily poor compared to the standards we'd expect for any other laboratory test we do on a day-to-day basis, such as sodium. So at least it doesn't directly answer your question. Indirectly, I think there's no reason to switch as long as you're using an assay which has had some form of reproducible validation compared with a standard. I'd be happy with you continuing it. And Sufei, I'll just paraphrase the second one too, if that's okay. Sure. It's the question of the strength of lupus anticoagulants. Again, we just didn't want to invest the energy required going too deeply into trying to parse out strong versus weak lupus anticoagulants. I realize that that's something that people talk about. I think for the purposes of this analysis, any lupus anticoagulant is going to be considered positive. We would need to do more validation work. And one of the things that hopefully centers will do, now that we've got what we feel is a more specific criteria, is to actually look at some of these questions around whether or not a weak titer lupus anticoagulant is a weaker predictor of first or recurrent thrombosis or other complications than a strong or high titer lupus anticoagulant, realizing that's not the correct terminology because we don't do titers. So Rita, I don't have a direct answer to your second one. I think if your lab defines a weak positive as a positive, then they would be included. And if your laboratory is insensitive to weak positives, then they would be excluded. Again, we can't possibly apply the same level of laboratory rigor to antiphospholipid antibody testing as we do to other places, because the testing just isn't as good. That's my technical answer is it's just not as good. And unfortunately, I don't see it getting any better. The fundamental problem that causes that is that we don't have a lot of evidence that the antibodies or phenomena that we measure, since lupus anticoagulant is a phenomenon, not an antibody, actually is causally related to the biology of the disease. If we had that evidence, then I would have more confidence, but we don't have that evidence in the same way that we do for many other antibody-mediated diseases like thyroid disease.
Okay, sounds great. Yep, thank you. So next question, I think feel free to try me, both speakers, is does pregnancy loss before 10 weeks now include chemical pregnancies?
I wouldn't think so, no. No. it's got to be a spontaneous abortion.
Yeah, you have to. So you're entirely correct. When we were talking about this in the panels, we would always prefer there to be some kind of documentation over and above a positive pregnancy test. I think the problem that everybody faces clinically is that when women come in and say they've had 7 losses, in many circumstances, those were purely chemical. The good news is, if that's all they've had, they only get 1 point for it. So the guidance document downgrades those. I agree with Dr. Cabral. If none of those had ultrasounds, so none of them had documented actual, like at least beginning stages of pregnancy, that certainly wouldn't technically qualify. I think it's going to be a threshold that's hard to cross with many women who present with multiple chemical pregnancies.
Okay. Sounds good. Thank you. So next comment, thank you for the excellent presentation. Should we understand from these new criteria now, there will be no point of looking at the lab criteria if the clinical domain is not met with the right pointage?
I would think so, yes, as well, because then what would be the idea? You want to go fishing without any clinical indication for your laboratory testing? That is, if I understand correctly, what you just asking, I wouldn't test it.
No, oh, go ahead.
Yeah, I would agree with that. I think, in maybe in a research project, if you're doing some kind of prospective evaluation, sure, but otherwise, don't go fishing. It doesn't help anybody when you have a 28-year-old woman who's got systemic lupus erythematosus and who you do testing, and she's got a lupus anticoagulant that's persistently positive, a high titer anti-cardiac antibody, has never had any clinical manifestations. What are you going to do with that person? Like, are you going to anticoagulate her? It's pretty speculative. I think you just need to be really careful about going fishing.
Yeah, the next question actually is probably a little bit related. Would you suggest to always look for APO in the context of thrombocytopenia, even if the patient never had thrombosis or obstetric events?
Yeah, if you ruled out on other reasons for the thrombocytopenia, and you are pretty sure that it's autoimmune thrombocytopenia, I would go ahead and do the antiphospholipid antibodies, and you will be able to at least have an idea about whether you have what I'm like to call hematological APS as a diagnosis. Now, like I said in my presentation, I don't have a good recommendation as to where or when to anticoagulate that particular patient, and that's the point. If you don't do the antiphospholipid antibodies in a patient who has ITP, then we will never know whether they are prone to develop thrombosis, as we know they are. The point is how we do intervene with those people. That's why I recommended hydroxychloroquine and the azathioprine to the patient I just presented, because we know that hydroxychloroquine may have, I'm not saying it will, to change the thrombosis rate in patients in general, more so in patients with thrombocytopenia. And the azathioprine is because, as we think this patient is prone to develop thrombosis, then the growth factor is going to be taper. So we're treating the thrombocytopenia with immunosuppressive medications, and it has worked so far.
Yeah, I think, again, there's people here who I work with, and there's on the call, and people who know me, and I've done a little bit of work in ITP over the years. And one of the frustrations of ITP is there's no diagnostic test for it except the passage of time in response to therapy. This is kind of a diagnostic test for ITP. If you have a person show up with a platelet count of 42, and I would say that lupus serology, HIV, other viral serologies, and lupus anticoagulant antibody are probably pretty standard in the evaluation of ITP. If they return and they're positive, that does suggest the person has ITP. So that then points you in a direction should they develop clinically significant thrombocytopenia in the future. So you might think, well, the answer to the last two questions are cognitively dissonant, and we're saying don't screen, and then we're saying screen, but they're done with different purposes in those two settings.
Yes, I agree.
Perfect. Next question from Luciana Bryce. Do you see this information being filtered to scientific groups such as ISTH, which usually recommend standards for laboratory criteria?
Yes, and the reason I say that with confidence is that there's not quite 100% overlap between this group that did this and every other group that does everything else in the world. But remember, this was hundreds of people who were involved in this. So for sure, the people who run the various processes for various organizations were involved in this, and I would be flabbergasted if there isn't a direct translation with the passage of time.
Sounds great. Next question from Dr. Lim, Wendy Lim. Many patients with white matter changes on neuroimaging get an APL testing. Do you consider white matter changes consistent with microvascular thrombosis that would meet clinical criteria? Thank you.
I don't think that has been proven by anybody. I know that, and we know that patients with antiphospholipid syndrome can have MS-like symptoms and MS-like white matter changes in the MRI. So that's as far as we can go. I'm not aware that it has been proven that it's microvascular, but I suspect it won't be, but it's just my intuition.
And next time Wendy and I are in clinic, she can wander down the hall and see all those patients I see come in with white matter lesions in their head. I think if you look at the patients that I have who have white matter lesions, most of them have another reason to suspect or prove that they have APS. I suspect that you have a 28-year-old woman who shows up with new neurologic symptoms. She has an MRI which shows white matter lesions. I suspect the stroke centers where she's likely to end up, or the MS clinic where she's likely to end up, will do APS testing. Never quite sure what to do with those people when they come to the clinic afterwards. I do get referrals on them. I don't routinely anticoagulate them unless they have something else that makes them look like APS. They might have fallen when they were 3 and had a little bit of an intracranial hemorrhage, and that's what caused their white matter lesion you can see now. So it's a bit of a tough question, but it can be simplified. If they have other signs or symptoms of having antiphospholipid syndrome, then I would use that as an indication for treatment. If they don't, then I have to think a bit harder about each individual case.
Okay, great. Next question from Dr. Rita Selby. He said, thanks, Mark, for the answer. And she has a new question for Dr. Cabral. Are you suggesting that we do APO lab workup after one miscarriage?
Yeah, very, very good question. The short answer is yes. And the reason why I'm suggesting that is that I sort of hinted it in my presentation. You don't want to wait for a woman to develop 2 or 3 more miscarriages in order to treat her for APS, with heparin during pregnancy and all that. I know that 10%, only 10% of first abortions, spontaneous abortions, are related to antiphospholipid or are positive for antiphospholipid antibodies. So the yield will be low. But I've done that, and mothers, thank you for doing that, because the next time they get pregnant, you are treating them appropriately, and they have had successful pregnancies after only one miscarriage that was diagnosed as being obstetric APS. So it's just a matter of humanity, I would say. If it's negative, then you rule out a potential successful treatment.
Okay.
I don't have anything to add.
Okay. All right. Next question is, according to the VT profile, should we test all women with hormone-related VT without a second minor risk factor?
So I'll say the short answer is no. because in the discussions that we had, there was David Garcia and I were the two thrombo people in the room, and then there was a mass of rheumatologists and others who were arrayed against us. And so we included, in the world of thrombosis, we can argue about sort of grades of secondary disease and what's a strong risk factor and what's a weak risk factor. We didn't get anywhere near that kind of complexity in the discussion. We would have counted a hormone-associated DVT as a secondary DVT, and so it wouldn't score high enough. If you had all you had was a hormone-associated DVT, you get 1 point. You couldn't meet the clinical criteria based on 1 point, so you shouldn't test as per the discussion we had earlier today.
Okay. Next question. Should laboratory evaluation for any of the new clinical domains and criteria be performed in acute setting or in an acute thrombotic or acute thrombocytopenic hemorrhagic setting?
No. Next question.
Okay.
Never test acutely, because there are so many things that can influence testing acutely. So, there's nothing, everybody who's dealt in this area, wow, they're lupus anticoagulant positive. Actually, they got a dose of heparin just before, and they just got a dose of, they got some apixaban. They were, no, don't, like, I can't think of a reason why you'd want to test. It's not going to change acute management in any circumstance. You want to wait until you're sure that everything's stable. The patient isn't anticoagulated. They haven't got other risk factors. Just wait. There's no huge rush to figure this out. The person's 28. They've got systemic lupus erythematosus. They have severe ITP. They've had a previous stroke. They have a history of pulmonary hemorrhage. They've had an adrenal hemorrhage, and now they show up with a new deep vein thrombosis. It's probably reasonable to assume that person has APS. Probably treat them with low molecular weight heparin, and then transition to warfarin, and then get them all stable and do the testing later if they haven't already had it. But otherwise, don't do testing acutely. It's just too hard to sort out.
Okay. Next question from Dennis Wharton. Is there still a role for anti-beta-glycoprotein 1 domain 1 or PS/PT testing? We see many requests for these tests.
You wanna speak?
Yeah, just me go quickly. So David Garcia and I and Debbie Jiang and Wendy, I think Wendy was on that paper, just published a systematic review in Blood, I think, or somewhere like that recently, showing that beta-2 glycoprotein 1 testing is useless. So, the broader question is, should we be doing beta-2 GP1 testing or not? Not whether we should be doing subdomains, in my opinion. There's no evidence that the subdomains predict anything at all. There's lots of enthusiasm, and lots of people will go to meetings and lots of presentations. If you're ever at one of those meetings, and I've been to all of them, challenge the people to show you the clinical evidence that those actually predict things. They just don't. Like, maybe they do, but they haven't proven it yet. And the reason why I say beta-2 GP1 testing is not useful is that it in my experience, it's rare or never that you see a person who's got a high titer persistently positive anti-cardiolipin antibody who doesn't have a high titer persistently positive beta-2 GP1. I've never seen a high titer beta-2 GP1 in isolation. So I know that there's a lot of talk about this, in my opinion, differs from essentially everybody else's. But if you want to see the evidence or lack thereof behind beta-2 GP1 testing, just do a little search on my name and Jiang, Jiang, or Garcia, or Wendy, and I think Wendy was on that paper. You will see us having done Debbie did a really nice summary of the evidence around beta-2 GP1 in the clinical world, and it is very poor.
Okay, thank you. And next one's from Alejandro Linder. There have been studies showing that if patients with confirmed cardio antibody or lupus anticoagulant are tested again at a later date, around 2 years, 50% will test negative. Can you comment about this, and what would be the implication for treatment in patients with previous thrombotic episodes, if any?
Very interested in Dr. Cabral's opinion about this.
Yes, I have not had yet to see one case like that. All my patients, or most of my patients, if you test them repeatedly, they are always positive. There's a lot of implications and maybe several explanations that the methodology wasn't done properly originally, and that's why the second lupus anticoagulant testing was negative. But other than speculate about that, I have not had yet to see a patient that becomes negative. Maybe because once I know that they're positive, I don't test them again, unless there are research purposes.
Yeah, it's super interesting. I would agree completely. I suspect that the majority of those cases that were initially positive and now negative were either moderate or low titer initially and just went away. They'd had an infection beforehand. But of the people who are, I think who make it to Dr. Corral's clinic or make it to see me generally, they're going to have persistent high titer findings because that's how they get to see us, right? So we have a little bit of a selection bias, but
Yeah,
I do think that particularly with isolated lupus anticoagulants, I am highly suspicious about the timing and nature of the initial test. Because it's just so easy to test after a person's had a single dose of anticoagulants. They went into a peripheral emerge, they got a dose of rivaroxaban, and they get tested 12 hours later. That could easily be a false positive associated with the rivaroxaban.
Okay. We're on the clock now. Would both speakers be okay? Maybe one more question?
Actually, I've got a meeting that just started. So if you want to stay on,
sorry.
I do have to drop off because I got a meeting right now.
Oh, that's fine. Yeah, we'll wrap up.
I'll be happy. Just one more.
Okay, you take one more. I can disappear. Thanks, guys.
Okay, thank you. Thank you, Dr. Crowther.
Thank you.
Yeah, we'll do one more and then I guess we'll have to wrap up. So it's from Dr. Chen and Bates. Women with recurrent losses, even with multi-APO persistently positive, won't meet criteria for APS. However, presumably you will continue to offer intervention based on previous studies, including lomogamulin plus aspirin, even if you don't classify them as APS anymore. This is confusing for me and many of my patients.
If I understand correctly, this patient has recurrent fetal loss and positive antiphospholipid antibodies.
Correct.
So she has antiphospholipid syndrome and can be treated as such with obstetric APS. That is the point. The diagnosis is different from the classification. And this is a patient that can absolutely be included in an obstetric APS project.
Great, thank you. So I think we'll wrap up since we're a little bit over the hours. Thank you. We'll have the slide come up real quick. So this just to show you that the recording will be available online. And please also stay tuned for our next seminar in March. Our website is currently down, but we'll be up in a day or two. And I really appreciate everybody's and appreciate Dr. Crowther and Dr. Corral's excellent talk. And thank you for everybody's participation.
Thank you very much. Bye-bye.
Yep.